But I'm very happy to be here today. So as Francesca said, I will have a short introduction to genetic testing and focus on chromosomal microarray. So I can imagine yesterday you heard a lot about the CNVs already, and for those who doesn't maybe know, hopefully now you will get a bit of the basics. And those that you are fluent with these things, now it's your time to check your emails, because rest of the day you won't be able to do it because we have a great setup. Good. So yes, so as Francesca also said, I'm the work group 2 leader, so on the kind of genetic testing part of this course action. And I think it's really great that we have so rich a network, that we have everybody from doing high throughput genetics to genetic counselors to also those that are working on the clinics maybe never have kind of even thought about genetic testing. So hopefully in the end of the network, we actually are everybody in the same page with all these different parts of it. So what you will hear about today is just the basic concept on kind of genetic variation. And then we will focus on the copy number variance and how we detect these genetic variants, and especially what is the questions in the clinics. And then going further to this network, why we want to talk about this in psychiatric genetics. And then I will just give some brief examples on CNVs in autism and population cohorts, which hopefully then lead a bit of the way for the rest of the talks today. So human genome and genetic variation. So we all have 3 billion base pairs, and kind of large part of it, they are the same, right? But what makes us unique is the genetic variation. And we really have a large amount of genetic variation that makes us unique. And we can categorize those based on different effects, but also different sizes. And if we start from this really small one, so one single base pair changes, so we can have them as substitutions, we can have insertions. So if you look at the upper row, then we have deletions. And then we go into a bit larger ones, so short insertions and deletions. So all these have a very local effects on the base where they are in the genome. So if they hit the gene, they might have very severe consequences. So they might kind of really cause a loss of function of a gene because there won't be any functional protein. But they might be also that they're very neutral. We don't have any differences in kind of, it's just a change, but it doesn't have any difference. Then we can go to these larger ones, which we'll talk a little bit more about. So copy number variations. And those are then that our genome is changed by a deletion. So deleting part of a chromosome, that will maybe cause a loss of many genes, a single gene, or in some cases, not at all. There is no genes in the region. We might have insertions. So that's also that there is kind of more content added to the base where this insertion is happening. There is duplications, so part of it are duplicated. So we have more of the same. Then we have also translocations. So there is a switch in the genome content that goes around. And then also inversions. And then, of course, we have chromosomal variation, which is the largest part. So we might have a 3 chromosome 21s causing a Down syndrome, and all the other anomalies of the chromosomes. And all these different genetic variation really then makes us unique, but also sometimes cause a disease. So these copy number variants, what we now really know about that jointly, they have a really large contribution to the genome variability among individuals. And this is also that if you think about comparing the single nucleotide variants, they really have just a local effect. But when you have a large deletion, a large duplication, it can really affect how the genome is organized, what genes are affected. So it's really have a large contribution, and also because it has usually a large contents. We know that in just the normal healthy control population, it's up to 10% of the genome is variable by these CNVs. And in cases that have disorders, this can also be, of course, larger, because we know that there are more larger CNVs affected. And as I've been saying, sometimes these CNVs, they don't have any phenotypic effect that we kind of really can quantify or measure. And these could be, so we all have these, and we might not know about it. Sometimes we need these CNVs for adaptation, or kind of just a human evolution. So we know many parts of the human genome that has actually many copies, and that has happened during the human evolution. So it has an adaptive function as well. But then we know also that these copy number variants can underlie a disorder or disease, and really can have a detrimental effects on our health. Other concepts that I want you to keep in mind during all the talks, also when we talk about. So when we talk about genetic variants, these can be rare or common in a population. So rare, it depends on what kind of definition people have. We can say that it's roughly lower than 1%. Sometimes you use a bit less frequency, and that's everybody's kind of favorite number to put on. Or then they can be common. So that said that it's fixed in the population, that we always see that these are kind of happening. But about these frequencies, it's good to think about that it is also population specific. So if you're studying a Chinese or Asian population, you cannot always rely on a reference sample that is coming from Sweden or coming from the US. So you really need to know what is the population that you're studying to know what is rare and what is common. Because otherwise, if you're interpreting your CNVs and you see that, oh, this is a really rare one, but then you might have one individual that has a different ancestry in your research cohort or a clinical cohort, and then you get a wrong interpretation of that variant. So that's very important to keep in mind. These variants can be de novo, so they are kind of only seen in the case or the child, and not in the parents. And these we find a lot in the neurodevelopmental disorders, and we can also interpret this a bit differently, because then we know that they might have more consequences, or then inherited. And genetic variants can also act in Mendelian fashion. So you know that it can be autosomal dominant. So we see that there is a parent that have a disorder, and then it has a 50% chance of kind of then giving it to the children, and then they also have disorder. Then autosomal recessive. So then it's a locus that needs to have both alleles affected, so one coming from the mother and coming from the father. And then we also have the X-linked dominant or recessive, when it's also acting a different way. And this information you need to know also when you're interpreting your variants from the clinics and also in research. So how we then kind of go about to really find all these variants. So we know they exist, and we have a really kind of history long going back to look at this. So already with the karyotyping, we can see a lot, actually, and still it is used in many of the clinical settings. So we can look at the chromosomal variation, so you can really easily look at the count of the chromosomes. You can look also balanced translocations, if you can map them, or large structural variation. So already with karyotyping, you could start looking at the copy number variants. Then we, of course, have Sanger sequencing. We have had it for a while now. But in the Sanger sequencing, if you want to have a look at the single nucleotide variants, or then copy number variants that are not very large, but then you need to know what you're looking at, that you can really design your kind of primers to hit the target. So then you need to have a prior information what you want to look at. Then we had DNA microarrays, which we'll talk a bit more about. And this has really, really revolutionized our genetic research, because then we can have a look at the whole genome-wide copy number variants, but also selected single nucleotide variants that were in the DNA microarrays. And we'll go more through about it. And now where we are now, I have a old picture here. It should be Nova-6, at least that we are kind of using a nanopores here. But so massive viral sequencing. So what we can really do now is to have resequencing of the exomes and the whole genomes in really short time. And these especially the whole genome sequencing, it has the capability to uncover all levels of genetic variants. So that's really kind of where the future is. And we'll just touch a bit about that later. But let's go for these ones, because this is still mostly used in the clinical settings. Not all of them will have time or money to have whole genome sequencing in the coming months, so it's really important that everybody know how this works. So we have two sets. So one is called array comparative genomic hybridization, so we call it ACGH. And this actually was coming from a cancer field, so in 1992, and I'm happy to see fellow Finns in the first author. So they were looking at this in solid tumors. So how to hybridize two samples to know what are the kind of copy number variants. And in here, in this plot from the paper, you can see that they identified the MYC gene kind of duplication. So in cancer, that's very normal that you have huge levels of MYC gene. And this is how it roughly looks now when you would do this in a clinic. So first, you need to, of course, have your patient DNA, and that you get after kind of explaining and counseling, as we know, so that what you will need to do. Then also in array CGH, you would have a control DNA sample. And then these are labeled with two different fluorescent dyes, and then applied to the microarray, which has already probes that these DNA samples will hybridize to. And then the hybridization, because you have the two samples, so they will compete about the hybridization. So you will then have fluorescent markers coming out. So in the lower end of this, you can see that when there is enough red and green, there's equal hybridization. Then when there is, for instance, more red, which is the control sample, then you might have a loss, so deletion. And then when there's more green, which is the patient sample, there might be a duplication. And then this kind of, depending on the platform, it goes to a specific computer algorithm that kind of measures the fluorescent signal, processes it, and then you will have an output that says where the DNA losses and gains are, the deletions and duplications. On the other hand, mostly that has been used in research is SNP arrays. So in SNP arrays, we can have two types of probes. So we have the non-polymorphic probes that can be really nicely used for detection of CNVs. Then we have the polymorphic probes to detect the genotypes. And then in SNP arrays, you don't really need two samples that we did in array CGH, but you actually have a single sample, so you can have your cases and your controls, but all of them would have one chip. And then what you will actually do is, you read both the intensity information, but then also the SNP status from that array. And then you can kind of use both of those information then to get the CNV status of the individual. And then for these ones, depending on the platform, so it could be Illumina, it could be Affymetrix, some other ones, there are multiple algorithms how you then process this data. So for the intensity, what we call also log2 intensity ratio, and then also the B allele frequencies. So based on these two information, you can really then get the CNV calls. But then, of course, because these are algorithms, they are not always correct. So sometimes it's also good to know that it is beneficial to run multiple algorithms, because then you can do a comparison or matching that, okay, we have 2, 3 algorithms calling the same variant, we can be more sure about it. So that's also good to keep in mind, especially if you're doing research in these. And then what you can do is then to annotate it, so then you compare the CNV status to a reference sample, and then also know the frequency of these when you can kind of look at the frequency in a population. And this is how it could be. So this is one of our patients, in an autism patient that All the pink ones, so they are single probes, and this is now only showing the log-2 ratio. And in this individual, it is a chromosome, zoom into a chromosome 9, and you can see here in the left side that there is a red box, and you can see that the indice goes lower. So that's a large deletion in this patient. And then, as it sometimes happens, they can have multiple CNVs in a row, and kind of with this large deletion, then it had a small duplication after the deletion. So it was a complex rearrangement de novo happening in this patient. But this is how kind of the data can be look like when you actually visualize it after the analysis with the algorithms. So just some considerations when selecting a chromosomal microarray platform. So you need to know resolution of the platform. So that would tell you kind of how big CNVs you can detect. Can you really go kind of to a really fine scale CNVs, detecting those that maybe hit only single exon or parts of a gene? Also, how the coverage is about the chromosomal microarray. So does it really have a nice genome coverage? Is it maybe designed that it will have only nice coverage on the OMIM genes? So, and all this information you will know about when kind of you start selecting it. And also really good to think about that if you have a platform that has both the polymorphic and non-polymorphic probes, you can actually detect more information than the CNVs. So you can really look at the stretches of homozygosity, which can give us information about, for instance, uniparental disomy or IBD, so identity by descent, which could indicate that the parents are consanguine. So that's also extra information that you can actually gain from the selecting a platform that has also the SNP probes. So also to keep in mind, if you're doing chromosomal microarray, you cannot really identify balanced translocations or insertion if it's a material that hasn't kind of been in the human genome before or not uncommon, and also balanced inversions. So that's really to keep in mind. So just about the future, so really moving towards the whole genome sequencing. So at least in Karolinska Institutet, in the kind of, Mia is there, she can tell you more about it. So what is kind of in the clinical side even, they are going towards whole genome sequencing, because that really has the potential to do only one single clinical test that you can detect all the genetic variants. So kind of, you can detect nicely the breakpoints. You can also get the translocations. You can get a lot of other information there. But of course, there are still needs to improve the algorithms and standardize the CNV detection pipeline. There's also a lot going on about the read length. So if you do whole genome sequencing in a NovaSeq, you might get 150 base pair read length, so that's how much the stretch of the read. But then with the nanobore and also backbio, you can get a huge kind of stretches, and then that's giving you better detection on the copy number variants, and also kind of stretching those genome parts that we haven't been able to sequence with other techniques. So I think there is a lot to go also with the whole genome sequencing, but it's really good to keep in mind that kind of in the end, most likely it will be cheaper to do that, then we start with the CMA, and then we do an exome, or then we do a gene panel. So when everything is there, I think that will be also a cheaper option to do in the clinics. So what can the genetic information tell us? So we've been talking about what we are all unique. So we can use it for different purposes. So for instance, you can have a very good guess of your ancestry. In some cases, it's very kind of maybe surprising. In some cases, like in me, not surprising at all. So if you just count so I'm 95% Finnish, which I am. So it can also tell about maybe your family relationships, and that's also kind of, for some people, can be surprising if you kind of look at the 23andMe kind of videos about they find their siblings and all these things. And of course, what we are interested in, it can give us information about the disorder, association, or disease underlying susceptibility loci. But none of these we would yet use in the clinics, right? So kind of what is actually then the questions in the clinics? So it can really in the clinical genetic testing, we can kind of screen the newborns to certain treatable conditions, diagnose a disease, pinpoint genetic factors underlying the disease that we know are already causal, predict the severity of a disease, help to choose the best medication and correct dose. So we have a pharmacogenomic task force as well, and also discover genetic variants that could be passed to the next generation. And the lifetime perspective here is really that you might counter genetic testing in all levels, kind of all ages in your life. So it could be already in some, you do a really kind of screening in utero because there is a susceptibility that there is a really severe disorder and you want to do genetic testing. And you can kind of have different of these throughout your life. And just to kind of work in the clinics, so you also need to interpret the genetic variants. So not all the variants that you would get, the clinics will report back. So just kind of to know what would be reported back. So most of the CNVs that you hear today, they would be kind of categorized as pathogenic or variant of unknown significance likely pathogenic. So those would be the ones that we have enough evidence that we can really report back, know what is the risks and what are the consequences. And then there is a lot of variants that we don't really know what they do. In some cases, we might have an idea that these could be underlying a disease, but we don't have enough statistical evidence, we don't have enough patients to really show it. And in some cases, we have seen that, okay, this is really a normal variation in the population. It doesn't do anything, so then we would call it benign. And for these interpretations, so you need the information about the genomic region, the gene contact, the effects of the variants, also maybe information on the family testing, and then also, of course, frequency in the population. So let's go briefly then in the genetic testing in neurodevelopment and psychiatric disorders. So we know that there is a complex interplay between genetics and environment and lots of different levels of variance, all the kind of size categories, also common and rare. So most likely we won't have the whole spectrum that would benefit on genetic testing in psychiatry or neurodevelopment directly, but maybe we could get kind of one of the tails that would actually have a high beneficial kind of information on the genetic testing. And just to kind of give a bit of a history perspective, this is nothing really new that we would be doing genetic testing in neurodevelopment or psychiatric disorders, because already in the 40s, Martin Bell really discovered Fragile X syndrome. And it is still one of the most common inherited cause of intellectual disability, also autism, and then also there is a kind of association with schizophrenia and other adult onset psychiatric disorders. And already in '69, there was a chromosomal test for Fragile X, and in '91, there was already discovered the mutation basis. And there are more than 100 single gene Mendelian disorders. I think now it's already coming up to thousands with all the new discoveries, but really this is something that the kind of clinical genetics has been using for years. But what would be then kind of what we know about the chromosome microarray use in these disorders? So 2010, there is this paper by Miller et al. Saying that chromosome microarray is the first-tier clinical diagnosis test for individuals with developmental disabilities, including autism and congenital anomalies. So this is like the framework saying that, okay, at least on those childhood onset disorders, we should use CMA as a first-tier set. There was this year the statement from the International Society of Psychiatric Genetics. Many of you have been actually working on this statement. And in that they say, it's a long test, so please read it, but I just took this part of it. So identification of de novo and rare mutation and CNVs may also have a place in management of serious psychiatric disorders. CNV testing may also prove useful for persons requesting counseling on familial risks. While the committee did not reach consensus on widespread use of CNV testing in adult onset disorders, most agreed that such tests may have value in cases with atypical presentation. So I guess this is already seeing that they are agreeing that there is use of this, and hopefully with this network we can come also maybe some more guidelines and a statement consensus. We'll see after a couple of years. But also just saying that kind of these CNVs, we cannot really pinpoint that they would be underlying a specific diagnosis. So they go across diagnosis. So they don't care about DSM-5 or kind of what kind of diagnosis the individuals have. So they have been found in different disorders. So this is the BCG paper on the schizophrenia CNVs, really nice paper. And there you can see some of the loci in the A panel. So for instance, there is 22q11.2 that we'll hear more about today. And then we have 15q, 16p, all of these. When you see, not sure if you see, most likely not, but this is an autism paper from Steve Shearer's group, and they are really showing the same CNV locus in autism. We even looked at a language disorder families that the probants had kind of really none other neurodevelopmental disorders than the language disorder, but they had siblings that had other neurodevelopmental disorders. We also found the same suspects, the CNVs. So this is just also saying that when you have the CNVs, they don't pinpoint the disorder. They just kind of say that there is a kind of risk for a broad range of brain disorders. Then shortly, I will give just a couple of examples how you can use this in your research. So this is from my postdoc time in Steve Shearer's group, really working closely with Bridget Berendandas, a great clinical geneticist, and doing great work on kind of phenotyping her ASD children. So we had 258 ASD children that were recruited when they got their diagnosis to the study. And what Bridget did was really a detailed clinical morphology explanation. So you heard yesterday about the phase 2 gene, right? So that's really kind of you're looking at, but this was the kind of old time doing it, really clinicians looking at the morphological explanation. Also, there was really throughout the review of their medical records, looking at the MRI and looking major congenital anomalies. And then there is a Professor Judith Miles in the US that has come with the scoring system that you can really kind of group the individuals. So this is a really heterogeneous group of autism children. And if you do the scoring system, so you can find that there is large minority, they wouldn't have a lot of different morphological features. They wouldn't have a major congenital anomalies. But then there are a quite large proportion still that would have a lot of these features. They might have already an anomaly when they were born, and lots of these, which we call the complex and equivocal group. So then we took this, and then we did both the CMA and whole exome sequencing, and we really wanted to look what would be the clinical diagnostic yield in these children. And I'm showing directly this. So if you take the whole cohort, 258 children, you can see that the CMA yield, which is in the light blue, it is roughly 9.5%, which is shown in many cohorts already throughout the world. In exome, we had a bit slighter yield, but that was also kind of not all the new gene discoveries had come. And in total, we had a bit more than 15%, because some of them had findings both from a CMA and whole exome sequencing. But when we use the kind of grouping system, the scoring system, in the essential group that didn't have a lot of these features, they had a much lower diagnostic yield. We then looked at that 2 other groups that had a lot of, and in the complex group, we could actually solve 40% of the cases. So that's already saying that this phase 2 gene, the morphological, what you're getting in the clinic, it is actually very useful also for your kind of genetic testing information. Is this more likely to get a diagnosis? And if there is, for instance, funding issues that you cannot afford these to everyone in your clinics, this information you can really use. Then we've been looking at, could we really pinpoint something about these CNV carriers in an intervention kind of perspective? So I'm working now with Professor Sven Balte at Karolinska, and also there was a PhD student who is also a clinical psychologist, Nora Choke-Olsson. And they were looking at the social skills training in autism and doing a large randomized controlled trial with 300 individuals. And in this, they included patients that had an IQ higher than 70. And they had complex or they had ASD with at least one comorbidity. So they had ADHD, depression, anxiety, kind of as a comorbidity. So it's not ASD only. And then they did their clinical trial, and they showed small effects, but mainly restricted on kind of adolescents in this cohort. But what I wanted to do is really to see, can we say anything about who is actually responding and who is not? So if you look at the raw data on the RCT, so those bucket plots, this is how individuals look like. So they had at pre-treatment, then they had post-treatment and follow-up, and how they were improving. And this is a score called social responsive scale. So, and if it's higher, then they have more symptoms. If it's lower, they have lower symptoms. So what we've been doing now is to do CNV detection, whole exome sequencing, also looking at the polygenic risk scores. But I will just show one results on the CMA. And here is just the characteristic. So we have more boys, as in most of the ASD cohorts, and they are roughly adolescents. Then they had, most of them have ADHD, but there are also some with anxiety and depression. And as you can see, the IQ is normal. So this is not maybe the typical ASD cohort, because then you would have those that have low as well. So what we found that roughly 35% had a rare GNV that also hit the gene. Of those, 7.2% were clinically significant. So this is also saying that if you're doing a CME in an autism cohort that have a normal IQ, you would also still find these CNVs. There is an association between the IQ and the CNV status, but still they would have normal. So we found 3 chromosomal abnormalities, and then also deletion, duplication, ASD risk genes. Interestingly, we had fewer CMV carriers in the comorbid depression cases, which is maybe interesting to know. And then we'll run a mixed linear model to look at the treatment intervention outcome, both in the control group and then the active group, and we also did AQ adjusted. So just having whatever size CNV or effect, but just that it's hitting GNV, didn't have a kind of association with the treatment outcome. However, when we stratified the cohort, if they had large impact CNVs, so larger than 500 kb, but also hitting a gene, we could see that the ones that were in the active social skills group, the ones with the CNVs actually were doing a bit worse or didn't have any improvements as well. Of course, this is very low sample sizes, but this is something to really follow up and start seeing what would be the intervention that would be more suitable for these large impact CMV carriers. And also maybe have a better assessment of the clinical profile if they would be suitable for the intervention. Just briefly to tune you into these population-based cohorts, with Dr. Johanna Martin, we did a kind of Swedish adolescent cohort approach to look at the CNVs. And in this, it's a twin cohort as well, and they have both clinical diagnosis, but then also screening for neuropsychiatric problems from 9 to 18 years of age. And there we also looked at CNVs and stratified there by their medium or large size, where we know that in the large CNVs, so if they have a clinical diagnosis, so that the CNVs are associated with the outcome. But interestingly, we could also see these in the screening tools. So if you had a higher kind of probability of having neuropsychiatric problems, but not the clinical diagnosis, there was also increased odds for, especially for these duplications in this population-based cohort. And we further wanted to look association by sex, and there we didn't see anything in the neuropsychiatric problems. However, in a small subsample that has anxiety and depression, where we saw that there was a association by sex differences, and the females with anxiety and depression in this cohort had a higher frequency of CNVs. And this also stayed the same when we adjusted for the MB levels, and the odds ratio was 4.3. So this is also something that we really don't know, is this that these girls have really anxiety depression, or is this kind of misdiagnosis, because these are the clinical diagnoses. So that would be interesting to follow up. So I'm now ending my talk. What I want you to know from this is We all have genetic variation. It makes us unique. But in some cases, a specific genetic variation can tell us important information about the disorder and help the families. We have different platforms that can identify different genetic variations. And keep in mind, in future, we might all get our whole genome sequenced. And then I also want you to kind of really emphasize the point that these recurrent CNVs are across different neuropsychiatric and psychiatric disorders, and they also kind of have the risk beyond the diagnosis, which we will hopefully hear more soon. So in the future, maybe genetic testing can give us the diagnosis, the right treatment, prognosis, and hopefully even prevention. So with that, I just thank my group and all the great collaborators and the engaged network. Thank you.